Welcome to NorCal EMS Medical Advisory meeting, the Run Review section. Today is March 3rd, 2015. So, case 1. EMS is dispatched code 3 to a local vet. They arrive to the vet clinic to find a 39-year-old woman outside in the company of her co-workers. She is alert and oriented ×4, which is probably better than I am. GCS is 15. She's pale, warm, and dry. This 39-year-old is complaining of chest tightness secondary to an SVT. She has a long history with reoccurring SVT, and she has taken her low pressure or her beta blocker du jour approximately 10 minutes prior to EMS arrival. She spoke with her cardiologist, who advised her to go to the emergency department. So, she attempted some vasovagal maneuvers and carotid massage with no change.
That had to be strange for to arrive on scene and having a patient doing their own carotid massage.
Yeah, and if she was elderly, I wouldn't necessarily recommend a carotid massage. Although you could be treating a whole new set of symptoms after you do the carotid massage. So, they had a pulse ox, vet's office, and she had, her heart rate was in the 200s. She doesn't have any chest pain, but she did have some chest tightness, no shortness of breath, no nausea, no vomiting. And she did complain of some dizziness. I probably would be dizzy if my heart rate was in the 200s. Started while she was at rest, sitting, and she reports, she's a pro, she's been through this before, that the last time it required adenosine.
She knew the name too.
Yeah, that's pretty good.
She did.
Oh, this is your call?
Yeah.
Okay. I'll try to be gentle on you then, Lilia.
Perfect. No,
The rest of us won't.
I understand that. So, first episode of SVT, September of last year, and these are reoccurring more and more frequently. It sounds like she needs to get to see an electrophysiologist and have them ablate her.
She actually had it scheduled for the next one.
Oh, so she had her ablation scheduled?
Yep.
Okay. So, she's on a regular regimen of low pressure, 25 milligrams in the morning and 25 at night. And she popped an extra one because her cardiologist said it might help and it should help. So, assessment is noted, vials is noted. Vagal maneuvers were attempted by having the patient blow into a syringe. I don't know about you guys, I've never had great success with vagal maneuvers. Now, I've had good success with the inadvertent diving reflex occasionally.
But that's not in our scope of practice.
Yes, I understand that's not within your
You
scope.
can't dump them into a bucket of water, ice water.
Yeah, well, the first time I saw that work is I was an intern and the medical student tripped and dumped the tray of ice slushy on the patient's lap, converted them right away. IV was unsuccessful the first time by a paramedic intern. We all got to learn sometime. No SC segment elevation or depression, and they did get one in the right wrist. Transported code 2, which I think is completely and totally appropriate. Blood glucose of 134. So, unfortunately, and I say unfortunately for EMS, the patient self-converted before they could give him adenosine. I love adenosine. I like the fusion beats and...
The intern must have been really upset.
Yeah.
Yes, because he was about to hook up the syringe with
Shit.
adenosine to the IV. And I'm like, wait. Sure. We captured it.
You snooze, you lose.
Wouldn't have missed that idea.
Yeah.
So the chest tightness is decreasing, and so is the dizziness, all rate related. Continues to deny any other complaints. 12 leads obtained, normal sinus, no SC segment changes, and the 12 lead is transported to the hospital.
Now, that last statement on there, Doc, that was in the report too?
Which,
Patient reported route, no questions, orders, and do not follow and do not give, that was in the report?
yes, it was.
Excellent.
That's
a hell of a report.
It was. I'm actually very excited that they documented that, because this young lady, it's amazing, 39 used to be old for me, now it's young, didn't need aspirin, didn't need nitroglycerin. This was all rate related. Only comment, and I apologize, is WNL, we never looked. That is.
Did you finally take it out of the abbreviations, because you said you were going to?
I did.
Yeah, you did.
It is not an approved.
Yes, right.
I have always disliked WNL within normal limits, because it really just says we never looked. That's one of my pet peeves. I've got lots, but that's one of the bigger ones. So, on arrival to the ED, patient's pink, warm, and dry with minimal chest pressure, vital signs, EKG. Again, we never looked.
But it's capitalized.
But it's capitalized.
You really did not.
We went through this with the.
On a patient's arrival to the ED, transfer is done. Copies of the EKGs are provided and left with the nurse. Allergies to the sulfa. She's on metoprolol, low pressor, B12, multivitamins. Pretty unremarkable exam at 13-18. Again, the rest of the exam is pretty unremarkable. Vital signs. Good blood pressure. Heart rate's a tad bit fast, yes, at 184. Respiratory rate of 16. And there you can see that between 1331 and 1335 they converted. Valsalva tried, no change. Now, I do have a question for our pre-hospital providers, and I'm not picking on the young lady who did the PCR, but I see this all the time, is blood glucose of 134 milligrams per deciliter.
The L should be capitalized.
Well, thank you very much, Mr. Lane, but my question to the providers is, why do a blood glucose?
If we start an IV, you get a blood glucose.
Just a matter of course.
The hospital typically will be like, well, did you get glucose while you're up?
Usually we only ask on altered or like dizziness or, I mean, she did have dizziness.
She's already
so
stuck.
that's it,
Especially if
so.
I draw blood.
Yeah,
There's
she's
always
already
just that
stuck in
little
one.
drop left, and you may as well do it because you can.
Save him a stick.
Okay, just curious.
It has become a pretty standard that you start an IV, you get a blood glucose. It's simple, the machine's right there, it doesn't take anything. You could be doing 6 other things while that machine is counting down, and you've just eliminated, guaranteed, that there wasn't something else going on.
Point taken.
Or we used to have a nurse
I
that
agree.
would ask us.
Eric Castillo, I agree with you, Eric. I think it's a non-diagnostic event which increases your risk of exposure to a risk of exposure with blood.
Well, you know, when I got trained, I'm not saying, thank you for that gesture, Mr. Lane. What I'm saying is, don't do a test unless you're willing to deal with the answer. So, just a comment. So here is great strip. You can, if you look at her ST segment, she's got a little depression, which is pretty common when you get up there in rates. She probably has she may have a little rate-related ischemia, which is not that unusual. So
That was 12 lead?
they're
Can you go back to the 12 lead duck? That's a 12 lead. No. Yeah.
Did you capture when she self-converted? Did you have that? Is that in here?
Yep,
Right there.
right there.
There it is. Wow.
Which is neat because she was actually telling us that all her cardiologists have not been able to capture her
Wow.
when she's converted herself.
Well, they'd probably like to see that.
Yeah, that's why I made sure
Yeah.
there's a copy.
Did she know it was coming, or did she just look at you and say, hey, it's converted? Did she know it?
No, she started feeling better, but I had noticed it on the monitor
Okay.
when I glanced over to look, and it was automatic. Couldn't.
Good.
It's really, this is great.
Yeah, that's a great one.
And if you look right here, here's a fusion beat.
Start.
Yeah.
So here you can start seeing pause, and there's the fusion beat, and then she goes straight into sinus. Great strip. Thank you. It was a lot of fun looking at these strips. And there's
You gotta send that to some of those, that's a textbook one.
that really is a textbook.
The manuals.
And it's perfect. Look at the compensatory pause here.
Yeah.
I'll kind of get your
Or it's
attention.
adenosine.
You'd almost think that was from medication.
You would. Well, I mean, if you look right here to about here would be a pause for adenosine. And the patient going, I don't feel so hot.
Oh, yeah, they do the cellular one.
I still remember the days we get pregnant.
Cutting the whole. I feel like I'm.
Now you're dating yourself.
But those are the ones where you just didn't know if they were ever gonna come out, you're getting atropine and everything ready. It's like how they were gonna convert.
So here's after she's converted. Pretty. It's interesting though. If you look at her T waves in lead 2 and her ST segment, swear that her T waves almost look a little peaked to me.
But the 12 lead didn't show,
No.
it showed a little depression, but not horrific.
So I think this is all rate related and non-ischemic, except related to her rate. And then here's her converted 12 lead. Well, so nothing that I'd get too excited about. She's got good R wave progression through the precordial into the lateral lead. So, documentation was real good, except for WNL. Good care. Poor intern was thwarted. Didn't get to give
It
adenosine.
was his first call, she
Very
said.
first call.
First call.
Yes.
Welcome to being an intern on an ambulance.
No kidding.
Hey, what a great call.
For a firefighter.
It's a great call. It really is. Care was most appropriate. I think the overall impression, good care, no questions, comments, or concerns. I don't think there are any changes to protocols. The teaching take-home points, you got to move faster if you want to use your adenosine. So it'd be interesting to find out.
Everything that was on there, I was really impressed with the amount of information that you were able to get off of the documentation.
Huge amount.
Not like some of those ones we saw from someplace else further
Oh,
south of here.
Let's stop beating around the bush. You're talking about Santa Clara. No, the documentation was stellar, and the care was good, and the documentation told the story, and every piece that needed to be there was there.
I mean, we got Mary, who's in the ED at a hospital. If they heard all that stuff, she would know exactly what wouldn't have, thank you for your report, goodbye. I mean, that's it. So,
Good run, good case. Thank you, Lilia.
Thank you.
Keep sending me these good cases. So,
Was there any follow-up? She got ablated, obviously?
Yeah, she
Did she ever
already had a
contact you
schedule.
again? Oh, okay, too bad.
that would be really interesting to find out what they found on ablation. Because it's interesting with the some of the ventricular arrhythmias, once they induce them to try to figure out what's going on, it's not always that easy to convert them out again. And that's when they sometimes do dual sequential defib, where they put two monitors on them and they have two different vectors to try to convert them. So, second case, responded code 2 for a female with a possible stroke. At the scene of the boarding care, meted by the caregivers.
it's not my patient, I just came on duty.
It's never their patient. Went to the kitchen, returned to find the patient slumped to the right, drooling, slurred speech, right facial droop, and the right hand contracted. Patient was last seen excellent at 16-20 hours. That's the. If I have one issue that the neurologists harp, drive me insane about, particularly at the stroke centers, is time last seen normal. You know, this one neurologist, Raul Gasado, said, do you have any idea how hard it is to figure out time last seen normal with an aphasic stroke patient? I'm like, okay, point taken. So the patient found sitting in the chair in their bedroom with a caregiver, positive stroke assessment, no chest pain, shortness of breath, no nausea or vomiting. Interestingly enough, caregiver provides a DNR. That doesn't mean, though, no care, which I think some of our providers forget, and ED docs too. Power of attorney, that took me a minute to figure out what POA was. I don't think that's an approved
I
abbreviation.
don't remember seeing that on our list when we were arguing that.
No, that wasn't on the list when we were arguing.
No, MNL was the big one. That was the big one.
Could not be reached. You know, the patient just gets the care that they need. Alert and oriented only to person. GCS of 14 with a reduction due to confusion. Skin signs, pale, warm, and dry. Interesting in the HET exam that she's got a right-sided gaze and a dilated right pupil with a sluggish reaction. When I read that here, first thoughts, well, before I say what I was thinking, what are people thinking with a right-sided gaze, dilated pupil, that's sluggish to react?
She's looking at the bleed.
What'd you say, Mary?
She's looking at her bleed.
Yeah, she's got a bleed.
Project stroke.
Yeah, exactly. That's a hemorrhagic stroke until proven otherwise in my mind. I don't think this is ischemic. There's other clues when we go farther on. Flaccid, pulse ox. Interesting though, she's got AFib. It'd be interesting, the meds weren't listed, which really would have helped, because I was wondering whether she was on Coumadin or not for her AFib. That's what I would want to know. Or is she on one of these new factor 10 inhibitors? These new things like Eliquis. Good drug, works well, don't need blood work. The problem is you really can't reverse them that easily, if at all. interesting with the trauma centers are starting to do with these patients who, this is a little aside, who fall, hit their head, who are on any of these drugs like Eliquis or Coumadin, and the initial head CT is normal. They're actually watching them somewhere between 4 and 12 hours and then rescanning them.
We don't have times for this particular call, do we? My question is they were transporting code 2 with a time of onset. I'm sure that they know that they have, there's the time frame for that.
Mm-hmm.
They're going, my guess is they're transporting code 2 to avoid the red lights and sirens, to aggravate the patient and increasing the potential for increased heart rate and increased stress, which could increase bleed or whatever else. But then the hospital's ordering them to upgrade to code 3. Did it save, were they coming from
It
Chester
doesn't.
and driving all the way to?
Doesn't
Hanover?
matter. That's an excellent point, Dan. My personal feeling on the matter is the hospital has no, I don't want to say right, but should not advise a EMS unit to go from code 2 to code 3. You look at the studies, and even in long transports, there's very little time. You know, they upgraded because it was, quote, a stroke alert. Yes, this was a stroke alert. And technically, the clock is ticking, because if this wasn't a hemorrhagic stroke and it was an ischemic stroke, the outcomes for these patients who are then given thrombolytics, the real cutoff point now is 60 minutes. And yes, they have
From time last seen normal.
time last seen normal. Yes, you have 3 hours, and in some areas where they're doing diffusion-weighted MRI, they're going up to 4.5. Some places are even doing wake-up strokes now, where the patient was last seen normal the night before, but that's after an MRI, not a CT. So I think it puts the patient at risk, because you're right, it's going to stress them out, raise their blood pressure, and if this is a bleed, they're going to get worse, puts the providers at risk, and every time you go in code 3, you have the wake effect. So I'm not a big proponent of code 3. I think it's a waste, and it puts people at risk. I know that's heresy, but I think it's dangerous. Here, blood sugar is normal. And interesting, hyperglycemia was a contraindication to thrombolytics, and that was just removed within the last month. Another interesting thing about oxygen at 4 liters per minute. The studies are starting to show, particularly in stroke and with the free radicals, and is you really need to titrate it to their SATs. And anything above 94% probably is a waste, and potentially long-term, the studies show those patients do worse. The MDAC's MAC committee, Emergency Medical Directors Association of California, I'm on that, and we're actually coming out with a white paper and looking at oxygen.
Thank you. It's so confusing still,
It is.
because everybody's training slightly differently.
Exactly. The only time where you have really to think about it in different terms is if you get a COPDer, and you really need to ask these people, well, what's their baseline? You know, because I see lots of reports where it says O2 saturation 96% on a high flow mask. You don't withhold the oxygen, but you got to titrate it. So it's really an evolving dynamic situation. Now, the patient vomited. Again, this makes me think intracranial bleed. It just does. So they're confused. Again, good documentation, right eye sluggish, left eye reactive, skin asymmetric, neck normal. I know this is not within the paramedic repertoire, but it'd be interesting if somebody had listened to her carotids to see if she had a bruit or something, which is a narrowing. I know it's not within paramedic scope, and you're smirking at me, Mr. Lane. Sorry, I can't turn off my brain. Heart normal, abdomen fine, GU normal. They never looked at the GU. Give me a break. That's just a normal preset. Upper extremity abnormal CSM. It would have been interesting if they had done a little bit more documentation. This is good. But if it was the grips were weak, or the flexion at the elbow for the biceps, just fine points. Now, yeah, they're hypertensive. I think this really makes me think of bleed. They're so hypertensive. And if I was taking care of this patient in the ED, I would be very careful at all about lowering their blood pressure. Because if you lower their blood pressure too rapidly, if it is an ischemic stroke, you're going to make it significantly worse with the watershed areas of their brain.
And all we have is nitro, and if I've heard of the protocol of 2 sprays of nitro, you could end up dumping their 200 down to 140, and then immediately within a couple of minutes bouncing it right back. And if you had a bleed, that bounce back would not be a real good thing.
I can tell you that they might arrest if their blood pressure suddenly went from 200 over 105 to say 130 over 70, because a huge portion of their brain is not perfusing, even larger than already. So again, pretty good times, everything looks pretty good. Now this is kind of interesting. Granted, the baseline's not real great, but if you look right through here, I'm really thinking, I'm having a hard time. I think this is sinus, but I'm not 100% certain that this is not doing all sorts of other weird rhythms, which really makes me think that it's CNS mediated. So 12 lead, better, AFib. Now, you know, the EKG says non-specific ST segment changes, probably digeffect. I don't think so. So, documentation I think was pretty good. Care was good. I don't have any issues or concerns.
Did it show their Los Angeles?
It had a positive Los Angeles stroke scale.
Cincinnati.
On Image Trend only has the option of Los Angeles.
Yeah, I explored that with Bill.
Unfortunately, yeah, most of us use the Cincinnati.
Right.
And that's what we're taught, but Image Trend, because it's from Southern California, is using the LLPDA or whatever it is, and it doesn't work. So I usually ignore that in my Image Trend thing and just in my documents write my Cincinnati of positive this, positive that, negative that.
Right. I did explore with Bill, and we were politely told no. Okay.
Is that going to change with the big updates coming out? If you know.
I don't know.
Okay. Case 3.
No, Eric, I'm sorry to interrupt.
Sure.
I had one more comment to bring in. We use the term last seen without symptoms because last seen normal is a bit subjective, and you can get answers like, well, he hasn't been normal since he was 15.
That's a good point, Neil. The neurologist, at least down in Santa Clara County, it's one of the get with the guidelines and points. But you're right. If they have, it is probably a more accurate term.
The other thing is what we encourage the field crew to do is get a contact number of the person who was the person who last saw them without symptoms.
Mm-hmm.
With the neurologist can talk to them directly and really pin down that timeline.
Yes, that's another excellent point. It's always a work in progress because people forget, but those are very good points to bring up, Neil. Thank you.
That's it. I'm done.
Okay. So this is another good case. Nausea, vomiting, back pain in a 55-year-old. Belly pain also. It really was initially kind of hard to sort out a little bit reading the PCR, and I don't think the patient was too clear. Husband, EMS finds fire and husband in attendance. About 12:30 in the afternoon, she began to have abdominal pain. She states that her pain is in her right quadrant and her thoracic area. And I'm thinking,
Non-traditional.
Well, I don't know. I started thinking, and again, it's tough trying. I've tried to get follow up on these patients, and I've not really been successful. I'm wondering whether it really depends on where in her back. It could be a aortic aneurysm, back and groin, as it dissects down. Could be a stone, if it's thoracic and in the back, leading into the groin. Not classic, but... So, nauseated, not vomited, no bowel movement. Interestingly enough, she's had her appendix and gallbladder removed. And I read she has a portacath in her right upper chest. And nowhere in the chart did it say why she had a portacath. So there's got to be a lot more to this story. Because, correct me if I'm wrong, but most patients you guys take care of in the field don't have portacaths to get access. So I was really trying to piece this together. So 12 lead, she's given Zofran, nothing. Interesting is in the history they talk about right-sided abdominal pain, but in the physical exam piece, nothing. Now she's on lots of different interesting medications. Prazolam, so she's got some anxiety. Carvedilol, so she's on a beta blocker.
HCTZ.
Yeah, she's on HCTZ, so a little high hypertension. She's on estradiol and progesterone, so she's being supplemented. I don't know why she was on prednisone. Unless she had some sort of autoimmune issue going on, which might explain the portacath. GIGU conditions.
I think that's one of those options.
One of the options.
On the image trend.
Probably for the omeprazole. They just didn't select GERD.
Or the famotidine. It's interesting she's on a proton pump inhibitor and H2 inhibitor. Vital signs, pretty unremarkable. Interesting strip. So those T waves are immense. So,
The baseline too.
Yeah, I was wondering.
so what are people thinking about when they look at this rhythm strip? I'm sorry, what, Neil?
Potassium.
Yeah.
T-wave, the potassium.
So here's her 12 lead. It's interesting she's got ischemia, or at least some ischemic changes in V1 and V2 with the flipped inverted T waves. And then 4, 5, and 6 really do have peak T waves. Then again, so does 2. So yeah, does she have some sort of renal issue going on? And you're right, Neil, is she hyperkalemic? So the document, I presented it because it's got lots of puzzles, but I have no answers, which is frustrating. I think the documentation probably could have been better because I just didn't get the whole picture. I think that the care was okay because there was nothing that they could do. But I really wanted more information. I was left kind of, it's kind of like have a joke without a punchline.
By looking, if I remember the vitals, and by looking at the assessment, it wasn't, definitely nothing showing up as extremist of any kind of, or critical in this patient, but just complaining. And if you look at her past medical history, she's got that anxiety and that depression and all that other stuff going on. The question, she's on lots of meds for her stomach anyway, so is this just one of those patients that is a frequent transporter to...
Oh, you cynic, you.
No, she didn't ask for any drugs, at least for us, pre-hospital, because didn't even want the IV access or anything else.
Right.
This almost looks like one of the patients that I've been dealing with for 20-some-odd years in the hospital and on the ambulance, and have, all these medical issues, and didn't mention allergies. Oh, allergies to Toradol, of course. I take my comment about your toxicity. Okay. So I didn't get a picture. Yeah, why she's got a portacat might be nice to know, but is this just one of those people that convinced the doctor that sometime in the past they needed a portacat and they've left it in for the last 20 years?
I don't know.
The fact that she has a portacap also make her, just looking at that, might make her more prone to clotting, and with her renal function impaired, maybe she either threw a clot down to a renal artery or even a mesenteric artery with that back pain.
Good point.
Active valve sounds, it kind of minimizes that too.
Yeah, although if she has mesenteric ischemia, you're right, Neil, she'd be complaining of pain way out of proportion to her exam.
Never had a pain scale, per se,
Right.
but I'm not sure. My feeling is that this patient may not have been able to give you a decent pain scale, simply because it sounds like this is a chronic issue with those meds that they're taking.
Yeah, and when I see prednisone, I'm just thinking autoimmune. So does she have lupus or something else going on? So lots of questions, not too many answers. So case 4, code 2 to a private residence for chest discomfort. Arrived at the residence, the can't get in. That's an oopsie. Radio called, said, yeah, the patient will be opening the door. They're met by this 78-year-old gentleman who was quote, just requesting a BP evaluation. Oh, it gets a little more interesting. So, when I read that, I'm like going, really? He called EMS for that?
Yes. Yes, that happens, yes.
So he's alert and oriented.
Tommy?
Yes.
Yes.
Somebody know what time it is?
12:48.
Go. Speaking in full sentences, no difficulty, no slurred speech. Patient provided documentation of 6 blood pressures he obtained with his home cuff. Has it ever been calibrated? No. He was concerned by his high blood pressure, so he called 911. So he has no real complaints other than his high blood pressure, no chest pain, shortness of breath, headache, blurred vision, nausea, vomiting. Classic patient, takes his medications,
It's in minor tones, it doesn't matter.
takes his blood pressure medications when he feels like it. Decided to take his metoprolol before EMS arrived because his blood pressure was so high. So, negative stroke scale, good capillary refill, motor, no pedal edema. I really did like the initial blood pressure of 280 over 140.
That definitely is high.
That kind of got my attention. He'd probably be a little more tachycardic if he hadn't taken his metoprolol. It's irregular. Cardiac monitor, sinus rhythm with occasional PVCs. Yeah, I'd probably advise him that he... Oh, there's another typo.
Blame it on the person who wrote the PCR.
Yeah, because you say you just transcribe it right
Yes.
over exactly how.
Oh, okay, guys. Thank you. So, they were nice. They secured the guy's residence, put him in the back of the LSU, and away they went. Again, code 2. No SC segment elevation. I do have the 12 lead, and it's another interesting 12 lead. Sinus rhythm with PVCs. O2, nasal cannula, no change. No questions or orders, still has no complaint. Exam, relatively unremarkable. Abdomen's unremarkable. Extremities, normal. Now, it's interesting when you look at this blood pressure. I'm like, wow, 198 over 106, 250 over 110. So, this guy probably lives at a high filling pressure. This is a patient who I would treat very gently in the ER. Because I would think that if you lower his blood pressure, giving him something like a labetalol, which is a beta blocker, an alpha, I probably would stroke him. I guess that'd be considered bad form.
Your insurance company might not be happy.
Yeah, my malpractice carrier would not be happy.
Well, he probably has a log of his blood pressure, though. If he has his own blood pressure cuff, he probably has some previous log that says, hey, what's your normal blood pressure here? Right, where he'd tell him.
One would hope.
Yeah.
Now this is kind of an interesting, I mean, if you look at lead 1, he's got some depression there. So he's at risk for having a cardiac event. So here's his 12 lead. I would say he probably has enough criteria for left ventricular hypertrophy. The other thing that I find very interesting is the size of his Q waves in V1 and V2. Kind of cut off V3 a little bit. He's probably had an anterior MI in the past. Just looking at those deep Q waves. He's got pretty deep Q waves in the inferior lead, in lead 3. So LVH, deep Q waves, Yeah, he doesn't have any ST segment elevation, but he's probably had an infarct in the past. So pretty good documentation. Care was fine. Again, there's a lot of controversy. There are some EMS systems that are using nitrates actually to lower blood pressure.
With my medic program, I get students from lots of different areas. And some of the protocols are very different. Some of them would say, well, their protocol, they'd probably be giving 2 shots of nitro, and some of them, the other ones, though, are saying they'd be doing 1 inch of nitro paste, which to me would be a little bit of better choice than 2 squirts of nitro or 2 nitro pills. But anyways, so I'm seeing those things that are out there in other agencies, whether it's the medical director or whether...
I have angst that, I'm worried about giving somebody nitroglycerin who's not been exposed to it before. It's radically absorbed, particularly transdermally, and it takes 15 to 20 minutes for it to start. The theory is it's more of a controlled release, and maybe you don't drop their pressure as quickly. I don't quite buy it. I think that giving 2 sprays of nitro is the equivalent of what we used to do in the ED with Procardia, and say, here, let's put this under your tongue and watch your blood pressure plummet like a rock. So I'm just leery. So here's a good one. Code 3 to a motor vehicle accident. Self-extricated walking toward the ambulance. Complaining of neck, back, and left arm pain. Positive rollover. Never did find out in the PCR why they were driving back to Reading from UC Davis Medical Center. But fell asleep. Full-size Dodge pickup. Unsure how many times the truck rolled. Went through a wire fence, came to rest, fortunately, upside right, wearing his shoulder and lap belt, self-extricated. A lot of damage. It takes a lot of force to rip off the rear tire. Deforming to the roof, so that does demonstrate they did roll. Starred the windshield. Interesting, no deformity of the steering wheel of the dashboard. And it must have been an older version because no airbags. That was kind of surprising. So patient's pale, cool, moist. So they're going to shock. Unable to remember the recent Thanksgiving holiday. He's probably got a traumatic brain injury. Although he's only got a small lac to the side of his head. Good documentation, no crepitus, deformity, or depressions noted. That was really very good. I was very pleased by that. Trachea midline, no JVD. With palpation, did complain of neck pain. Again, very good. Again, no crepitus or bruising. Good documentation. No subcutaneous emphysema. Abdomen non-tender. Although it's interesting, the back they say no trauma, deformities felt upon palpation. But just underneath it says complaining of high back pain during C-spine. So a little confusing documentation. I did like the fact that they said no incontinence. Deformity node to the left shoulder joint with soft tissue swelling, no crepitus. So, go on, Dan.
Stopping right here and thinking to our last discussion on C-spine and our upcoming C-spine. There's pain to the back, but no deformities. Walking around. Would this patient then be a candidate for a C-spine, a C-collar, and a being firmly attached to the stretcher gurney so they didn't move as opposed to a backboard?
It depends, Dan, on who you ask.
I'm asking you, my medical director.
Okay. Well, let's if you talk to a trauma surgeon, they need to be on a hardboard. Padded, so they don't get
But-
skin breakdown.
But nobody pads them. Nobody's got padding on their backboards.
Right.
It's just, I haven't seen padding on a backboard very often.
Right, so you put a blanket or something. My feeling on the matter, since he was self-extricated, is you put a collar on him, you lie him down, and say, "Don't move."
Or you put him in a semi-Fowler's if he's having a little trouble, it's more comfortable for him to breathe or whatever else, because we don't know what size he is.
Well, I mean, the thing that I'd love to get in NorCal are the vacuum splints.
Oh, yes, those are wonderful.
Should be a good candidate for just a KET device. That way you can keep in a semi-Fowler and still keep their alignment.
Mm-hmm. Do I think they need to be trussed up like a
Turkey.
turkey? No. What I'm thinking, this guy probably has a brachial plexus injury on the left.
Okay.
So cap refill, 3 seconds. Difficulty palpating radial pulse. So I'm thinking his subclavian artery, radial, unable to move the arm, decreased sensation. So I'm really thinking he's got the neurovascular bundle is not normal.
You read ahead. That's not fair.
Who, me? Yeah. Can't win them all, Neil. So,
What is TTA?
I was hoping somebody could tell me. Trauma team activation? I have no clue. Huh?
That could be. That would at least make.
I don't know, I made it up. I have no idea what TTA is. It's not one of those approved abbreviations that we've been talking about.
Yes, that's a trauma team activation.
Thank you, Neil. Full C-spine placed on the stretcher and loaded to the ambulance. Code 3. Why?
There is no reason, other than the trauma surgeon wants him a few seconds earlier. Vitals were, he has an issue, but
Right. 1 to 2 minutes, 3 minutes max is not going to make a difference. Position the arm next to the thoracic region. Start the IVs. The cardiac monitor, when I looked at it, actually looked like V-fib. It was unintelligible, so I did not. So O2 applied, blood glucose done. So this was a little confusing. I was trying to figure out, they were considering going to Sacramento, but they ended up going to their local hospital. Interesting that CHP was there, and he blew 0 on their breathalyzer. No further orders or questions arrived at the hospital without incident. Interesting, though.
that was confusing.
Yeah, I
Are they
actually...
going to Sacramento? Are they patient report given to hospital before drive to Sacramento? Bless you.
God bless.
Bless you. Are they taking,
I couldn't tell.
was this one of those that was like maybe, why would anybody was this a NorCal PCR?
No, this was not an NorCal
Okay.
PCR.
All right.
Long story it was an NorCal. Long story short is they went to a regional trauma center up in NorCal. They didn't go to Sacramento. It was very confusing the way it was written. I had a hard time sorting through it. Interesting, his medications are medical marijuana. So I do have some angst with some of the documentation. Normal.
Can't be, because they said he had decreased.
Right. So, no. Eyes reactive good, cold, clammy, pale, shocky. Head and neck, normal. Chest assessment, fine. Heart, normal. And on the bottom it says extremities. So, they're a little inconsistent. Blood pressures are all good. It's interesting, though, that he's relatively tachycardic considering the amount of trauma that he just,
Not tac.
Yeah, he's not tachycardic. He's
No,
sick.
bradycardic.
I meant bradycardic.
Yeah.
The other thing, too, is this. 139 over 113. I don't believe it.
It's an automatic machine.
It's an automatic
It's an
machine.
automatic machine.
Well, I've seen automatic machines take blood pressures on gurneys that they've been attached to also.
You know what, if you're using one of those and you look over and you see that and all of a sudden it's all wrong, you go like this. Restart. I can't tell you how many times I've done that and asked the patient to quit going like this.
Just quit making a fist or a
Fist
muscle.
or holding on real tight, or, here, let me hold your arm, we just want to get this one done right. And it changes it back to a normal, their normal.
Right. If you have a spurious result, what do? You recheck it.
Or not put it on your PCR.
Spinal immobilization, I don't know how they immobilized him, whether it was with a backboard or not. Unclear.
Had a little trouble with their chronology of events there on that last slide also.
Yeah.
And
Yes.
The hemorrhage to the normal extremity.
Right. I just record it, I don't write them. Interesting, his blood glucose was a little elevated. That could be due to the epinephrine release that he had. 6 liters, normal saline at the KVO. So the documentation, I think, could have been better. Overall, I think the care was appropriate. Overall impression, I really think the guy's got a brachial plexus injury with maybe a subclavian artery issue. It'd be interesting to see if he had his window rolled down and whether his left arm went out of the vehicle's cab and got rolled over on. That is what I really would want to know. Okay, so it's time for the exam.